Call upon stage our today's moderator for the research workshop, Dr. Shambhu S. Shamajdar. He is an MBBS MD DM Clinical Pharmacology Gold Medalist, PG Diploma in End-to-End Diabetes Fellowship in we welcome you, sir, on behalf of DRWA.
Yes,
Over to you, sir.
Good morning, all. So today we'll start the research workshop, and I think may I invite Dr. Kesri, please, in the dais. Dr. Kesri had done his MD from Odisha State Medical University, so he's a very renowned researcher and diabetologist. Also, may I invite Dr. Alok Modi in the stage, please. And again, Dr. Alok Modi needs no introduction, and he is one of the fellow who is trying to build up the AI literacy in our country amongst doctors. So welcome, Dr. Modi. So today, what we plan, we will have my presentation, a little bit overview, because 40 minutes is not a time to cover the topics on research. We'll touch upon the basics of clinical research. As a beginners, what are the area we should focus to conduct clinical research? Can you give me my slides? Okay. So I think when we talk about clinical research, we should start our journey with respect to this great guy, Dr. James Lind. And he had documented his research finding in this book, that is Treatise of Scurvy, and this ship we can see, that is the HMS Salisbury, where the first time something called as clinical trial happened in this universe. So what he had done, he took 12 sick sailors, because that was the time when UK had faced lots of mortality amongst their army people due to scurvy, not due to the Spanish army men. So that is their first thought, how we can tackle that. And he had done this research in that ship, 12 sick sailors. They were divided in 6 pairs. And what actually works? 2 oranges and 1 lemon. That works. So ultimately, this was done in 20th May 1747, but British made citrus compulsory in the diet of sailors in 1795. So this timeline is important, and till today we also know, after conducting research, it takes time to publish and to increase the noise about that particular research. Sometimes it takes more time. There are 4 important points from that Lind's journey. That is, number 1, first of all, he made all subjects, they were in similar conditions. So, like was compared with like, the control variables. So that is a very important basics for any clinical research. Second point, what happened? After this finding, they had made that juice in inspissated form. And we know what happened to the vitamin C if we warm it. And that is why the next persons, when they were using that, they were not cured. So again, there was some confusion. And it is again very much associated with all type of clinical research. We should widen our views. And when he was writing that Lind's treatise, he had also gone through some previous findings from Vasco da Gama, from Richard Hawkins, who is from a very known figure from Brazil. They were also using that orange and lemon. And we know in clinical research, the review of literature is important. Previous documentations are important. So this is again another lesson. And one of the secondary outcome for this particular research was how they make the seawater distilled to get the fresh water. So that was the secondary outcome for that particular research, and that was an important technology in 18th century. Now just coming to this, we can say landmark trial, empiric outcome. We always go through these beautiful findings, but often we missed, we just see this and tell this empagliflozin working great. But what is important, again if we go back to the Lind's lesson, then we'll find we should check whether in the baseline the two groups are matched or not. This will we not get from the very first paper. Sometimes we need to search for the supplementary items. And this is again the baseline characteristics, they were matched. Apart from that, another important thing I just want to focus here. If you see in that empiric outcome, the secondary outcome they also had done, and many research we have secondary outcome. Why it is important, secondary outcome? Just like Lind's treatise, they make a secondary outcome was the how to distill water. So secondary outcome, they are coming from some post hoc analysis, and that had shown some benefits in terms of renal outcome. But when we talk about post hoc analysis, what is the correct option here? What is the importance of post hoc analysis in scientific research? And what caution should be exercised in its interpretation? If the option is post hoc analysis is primarily used for confirming hypothesis established by experiments and its results are always definitive, how many of so sir is telling about B. So I am again not going all. So post hoc analysis is crucial for generating hypothesis. So by post hoc analysis we can generate hypothesis from existing data, but its conclusion should be viewed with skepticism until we can confirm it with some prospective studies. So that is why they give some signal, and we know the EMPA-Kidney that published also. Now we can say, yes, empagliflozin is going to give some benefit in terms of kidney outcome. Now again, this is a very important diagram I think we all should understand, because the confusion arises whether I am doing an experimental study or whether I am doing an observational research. The first question, the basic question we should ask ourselves as investigator, if I am assigning the exposure, as investigator, if I am deciding which group will take placebo and which group will take empagliflozin, if it is yes, then it is an experimental study. If it is not, if someone else is prescribing, I am just observing. So that is the observational study. And in case of experimental study, there is again another question we should ask ourselves. If the allocation is randomized by some methods, if it is yes, then it is a randomized controlled trial. If it is not, then it is a non-randomized controlled trial. When we talk about observational study, then we need to ask whether there is some comparison group. Sometimes we can compare with the baseline. There may be one group, but I am comparing the results from the baseline to the follow-up. So if there is no comparison group, that is a descriptive study. Most of the prescription utilization pattern studies nowadays done by our postgraduate students, they are descriptive studies. Yes, there could be some analysis, but they are not true analytical study. But if it is comparison, then that is an analytical study. Then we need to ask the direction. If I am going forward, that is from exposure to outcome, I am giving empagliflozin, and then I want to see the outcome, the forward moving, then that is a cohort study. But if some events already happened, I have to go back. So from outcome to exposure, that is the case control study. But if I am doing something called a snapshot, in this population, how many of you have diabetes? I want to screen, and that is a cross-sectional study. So this is something basics we need to know, and I think all of us know the different phases of clinical trial. Before entering into the phases of clinical trial, when we talk about again a clinical trial, that means I am assigning the exposure. We need to understand two things. It could be regulatory clinical trial. That means regulators are seeing what I am doing, and generally all the development process, drug development process, they are the regulatory clinical trials, starting from phase 1 to phase 2 to phase 3. Here, one terminology is we need to remember when we are doing regulatory clinical trials, especially the phase 1, phase 2, and phase 3 clinical trial, we are doing with some drugs, but that drug is investigational new drug, IND. That we need to remember. When everything happened, we submit the phase 3 report, the regulators passed, they give the approval. If we are doing some phase 4 clinical trial with that particular drug, that is the new drug we are doing with. So after phase 3, we need to submit the NDA, new drug application, and then we'll get the approval and we do the trials. So phase 1 means safety and tolerability, phase 2 means proof of concept, and phase 3 is clinical efficacy and safety outcomes. When we talk about research, we need to know something about these knee jerks. That means when we are hammering our knee, there will be some knee-jerk reactions. These are few events in the field of clinical research, starting from the Nazi people. They were exposed to extremes of cold or extremes of hot, just to see what are the physiological changes happen inside human until they die. Then we can see here, I think the picture is not that clear. This is a Tuskegee syphilis trial. So there, the Negroes, they were being infected with syphilis, and just without providing any treatment, already penicillin was there, they were tested for how the syphilis, the natural course happened until they died. So this all, we can see here, the Willowbrook study, the mentally retarded students, they were exposed to hepatitis A just to see the natural course of hepatitis A. So this is a beautiful girl, and I think all of us know this is a case of phocomelia, what happened with thalidomide disaster. And this was that, I think a very great doctor, first time who had noticed this, Dr. McBride from Austria. He had told there is something wrong happening in Europe. And we should salute this lady, Kelsey, from US FDA. He had stopped the entry of thalidomide in USA, and that is why US mothers, they were safe. So these are few important issues when we talk about clinical research, the ethical challenges. The regulations and guidelines are important. I think we have our regulators, CDSCO, ICMR, who is the apex body. They are not regulators, but they are telling us about some guidelines, how to conduct ethically clinical research. Again, if we go by this, just for an easy understanding, if I am doing experimental study, randomized control trials, then we have New Drug Clinical Trial Rule 2019, which tells us how to conduct clinical trial. And generally, all the observational studies, for that, they have guideline by ICMR. Again, when we talk about responsibilities of key stakeholders in clinical trial, there are certain people, including sponsors, investigators, but most important stakeholder is the study participants that we need to understand. And this line is very important. We do research for the pupil, and that should be with the pupil, not on the pupil. So they are not the guinea pig. And that is why this is in nutshell different relationship of stakeholders, starting from sponsor. Sponsor will decide who will be the investigator. They will talk with the regulatory authorities to conduct, to get the permission, and there is a role of site administrator, the principal, director of the institute, the institutional review board and ethics committee is there, and the subjects. So when we talk about clinical research ethics, I think our ancestors had written this beautifully. This is a slok from Mahabharata. Vidur told, Atmanah pratikulani pareshuna samacharit. That means, do unto others what you would like others to do unto you. So if I am thinking about this particular sloka, and I am thinking someone else who is sitting in front of me as clinical research participant, and I am also thinking that if I am keeping myself in that particular chair, how I should behave. So that can give us the ethical clinical research. And always we need to remember, when we conduct any clinical research, we should not be biased. It could be success, it could be failure. So that is what Sri Krishna told, Yogastha Kuru Karmani, Swangang Tyaktva Dhananjaya, Siddho Asiddho Samo Bhutva, Samattang Yogo Uchyate. So equanimity is the rule of life. Again, in clinical research also, we should follow the rule of equanimity. I think we have a great speaker now who had done a very good job. May I ask Dr. Kesri to share his views, and especially if you can tell us about the journey, how you had conducted a specific program. So it would be great for our today's listeners. So please come here and you can deliver.
So thank you so much. First of all, thank you, Dr. Patni and team, for inviting me and giving me this wonderful opportunity to be in front of all of you here. So the topic given to me was research design and methodology. And this basically is a workshop meant to be for the beginners who want to delve in and foray into the field of research, prove their mettle there. Research is very important, especially important in these times, in developing new therapies, new interventions, in bringing better quality of treatment and improving lives of our patient. So, first of all, Dr. Shambhu I was very grateful to him because he's taken over a lot of the topics that I wanted to show you, and he's already discussed them in detail. Thank you so much. So there's always, whenever we are discussing with our seniors in our classes, so what in your opinion is more important? The clinical expertise, the experience, or external evidence? So I would like you to raise hands, those who believe that their expertise, their experience is more important. No? Well, this is what we start with here, the importance of evidence-based medicine. So in 1971, Archibald Cochrane wrote a book, Evidence and Efficiency, in which he actually showed that many of the theories and many of the practices, they were actually myths. They did not correspond to reality. So he raised this issue, which ultimately turned into Archibald Cochrane collaboration in 1995. Nowadays, there's abundance of literature. We have so many articles, media, they're very confusing. So how do we know what we should follow, what is important, what is not important? So for this, we have the evidence-based medicine, which is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. What is research? Research is a systematic process. It uses scientific methods to generate new knowledge that can be used to solve a query or improve on the existing system. Here, the most important thing that we realize after all is the research question. You must have a question, you must have a good question of which you are seeking the answer. Or there has to be a problem which needs to resolve. A good research starts from there. And this is where we started what I'm going to talk about in future. So research question is very important. It should be significant, it should be in context, and it should be practically answerable. This is also very important. If you set out to research something which is not practically answerable today, we would not get any results. And obviously that question should not have been answered. We should try not to redo things which have already been done and already proven. So where we start with, first we start with a systematic literature review. We review the literature, go through it, and sometimes that would help us in answering our question. Maybe the research just has to be refined. Maybe the research question has to be refined. So once you've gone through all this, then is the next important step. That is the acronym PICO. Stands for Population, Intervention, Comparison, and Outcomes. So these are the key elements of any medical research, whatever you do. So population is the population that is to be studied. That may not necessarily be human beings, that may be laboratory animals or whatever. So we have to first of all define that population. These are the different types of research. It's a very busy slide. I won't go into the details, but you all know about these. So again, this diagram has been shown earlier. Now you have decided the population that needs to be studied. You have the question, you have done research, you have done the systematic literature review, you know what you're looking for, you know this is the problem. How do you go on ahead? So you decide your research design, because research has to be a systematic inquiry, a methodological inquiry. So what happens is, as Dr. Sham was telling, first of all you decide whether you are going to intervene or not. Or you are just going to examine a natural exposure which has been going on, which you have not prescribed, like a disease, like hyperglycemia, like high blood pressure. Those people already have that. You are not creating the disease, as he was showing. So it all starts with this. So these are the two basic types of research. One is observational, where you don't intervene, you just follow on what you're seeing. And the other is experimental research, where you assign the intervention, like you assign a drug, you do a surgical procedure, or you do a therapeutic procedure, or anything which you have done to a patient, and you select the groups, and you say that this person is going to undergo this and this person is not. So observational study, this is the most common of all the studies that we see. The most of the studies that are being done are actually observational studies. So what are observational studies? These are actually hypothesis generating studies. They ask questions: what, who, where, when. So observational study is a study in which knowledge from the treatment of persons with drugs is analyzed and used for using the epidemiological methods. In these studies, the diagnosis, treatment, and monitoring are performed exclusively according to the medical practices and not according to the specified protocols. So we just follow the exposure of persons, patients, or whatever, and take the outcomes from them and examine them. So now, if in the observational study, there are two groups. The comparison groups, like either one is the control or the groups being compared. If there is a comparison group assigned, then if there is no comparison group assigned, then it becomes a descriptive study. So descriptive studies are very common that we know of: case reports, case series. This is actually the earliest form of research. Research earlier used to be in the form of case series, case reports, and there's a unique case which is out of norm, atypical. So they are descriptive, they don't have comparators, they cannot be generalized, and they cannot establish causation. Case series are coherent and consecutive set of similar cases. Now, if there's a comparison group, then these studies, these observation studies become analytical studies. So here it depends, as Dr. Shambhu was showing, the direction from where you start. In cohort study, when you start the study, then you assign then the exposure is there. That is, you study the outcome of, see the outcome of the study after some particular time or interval of initiating the exposure, of the beginning of the exposure. So the results come out after some time. So this is a cohort study. So cohort studies compare two groups, subjects with exposure risk factors to the subjects without exposure risk factors. And they're usually prospective, with two healthy groups observed over time, exposed or unexposed. They sometimes may be retrospective also. They're used when the suspected exposure is known and disease incidence is high, but the drawback side is time consuming, expensive, and they can be selection and information bias. Now, in the analytical study, when you already know the outcome and you go back in time and see what happened to these patients when they developed the disease or when they were just exposed, and you see the result of that exposure now, such studies are called case control studies. So in the present, you already have the outcome, you go back in time, you search their records or do interview, call them, ask them, like we are having, for example, in a study assessing the lung cancer in the smokers. So when did they start smoking? How many years back? How many packs they smoked? So these would be a case control study with a control group which was not exposed. So case control studies are study designs that compare two groups, cases versus controlled, assess prevalence, differences in risk factors, and the incidence rate cannot be calculated. They're prone to selection and recall bias. So again, here there must be a matched group, and the matching is defined by the process of selecting the controls so that they are similar to cases in certain characteristics such as age, race, sex, socioeconomic status, and occupation. Now, cross-sectional studies. Cross-sectional studies, what they do is that they give you a snapshot of what is happening. Maybe a relationship between an exposure and the result, but in a given period of time, maybe a month, maybe the same day, maybe the same year. One of the biggest examples today is the INDIAP study, where we are assessing the diabetes, the level of control, dyslipidemia, etc., etc. So it gives you a snapshot in a particular period of time. Then interventional studies, I think Dr. Shambhu has very well elucidated these. These are hypothesis testing studies. You have formed a hypothesis from your case series, then from your observational studies, then the observational analytical studies. You have formed a hypothesis. Now you are testing the hypothesis whether it actually works, it is the causation or not. So they study the effect of an intervention. Convincing evidence for demonstration of causality is generated from these studies. And they're used for studying or demonstrating clinical or pharmacological properties of drugs. Similarly, I think these have already been well explained, so I'll just skip some slides. Randomization, non-randomization, when groups are assigned randomly, so the population is selected, and of that selected population, random allocation is made to groups who would be intervened and who would not be intervened. So these are randomized and non-randomized trials, and they are crossover trials when the groups themselves become their own control. So a particular group is exposed for a period of time, let's say 1 month or 2 months to the drug, and the other group is not exposed. Then after a washout period, the same group which was not exposed is exposed to the drug or the intervention. So the limitations of both of these, and these are clinical trials. Again, I won't go into the details because Dr. Shambhu has talked about these. So the key elements of any robust study design would be randomization. Randomization is very important because that prevents the bias. So randomization to prevent bias due to subject selection. It ensures comparability between the groups. Similar baseline characteristics prior to randomization are very important. Randomization can be a very simple coin flip randomization. Blinding is very important when it is used to decrease influence associated with the knowledge of being in a particular group. You all know about the placebo effect, the nocebo effect. So it can be single-blinded, double-blinded, or triple-blinded. Bias is defined as any systematic error in the design, conduct, or analysis of a study that results in a mistaken estimate of exposure's effect on the risk of the disease. So there can be selection bias, there can be information bias, there can be an observer bias. And secondary research is very important because this forms the top of the evidence-based medicines, the top pyramid, systematic review, and meta-analysis. I think Dr. Shambhu has talked about these, so I'm going to details. Now I would like to talk about briefly something which Dr. Shambhu has elucidated to. This is my journey into research. It started more than a decade back. This is one of the important studies that I think I've come up with. It's a novel diabetes management score. So I felt there was a need for scoring because there are three pillars of diabetes management. One is the medication that we are giving, the other is the diet compliance, and the third is the physical activity or exercise. Because we've seen that other than medication, just diet compliance, lifestyle modification may give HbA1c reduction from 2% and more, sometimes even more than that. So we understand that lifestyle modification, which includes diet and physical activity, is very important. But somehow we don't get so much time in our daily practice to assess that, and we don't recall because we have so many patients. So how do we know what was the condition, how this patient was doing last visit, and what has changed over a period of time? We don't know that. So we must somehow fix that numerically so that when the patient comes to us next time, we are able to assess, you've been not following your diet now, are you taking that or not? Or the patient, you have given a prescription, but the patient is not taking the medication. So how do you know that? For this, we came up with the score. So the maximum score is 5, and of the 5 would give 4, 3, 2, and 1. As you can see here, 5 is very good, 4 is good, 3 is fair, 2 is unsatisfactory, poor, and an absence of result. So we did this, we don't have so much time, so I'll go over quickly. So maximum score was 5 in all these 3 domains, whether the patient is compliant with medication, taking them daily or not. Similarly with diet, whether the patient is following the diet you've prescribed or not, and exercise, whether the patient is doing sufficient exercise that you've prescribed or not, because you always do that in the first visit. So what we did was we formed, this is our EMR, this is a customized EMR that I myself developed, and we would score these over a period of time as the patient visits, and we would observe the changes in these scores. So we formed a composite score of all these 3 scores. And we extracted data from our EMR. So we had data of about, we have around 11,000 scores of more than 3,000 patients, 5,000 plus HbA1cs, 8,000 fasting values. So we wanted to see whether this score anyhow correlates with the outcome, with the glycemic outcomes. That is the HbA1c, the sugar levels or not. So what we did a Pearson's analysis of these scores versus the total number of outcomes. So we found a moderate outcome when we compared all the scores with all the outcomes. As you can see, for HbA1c versus the score, it is 0.36, and with fasting 0.37, and PPG and PP 0.44. When we did a similar analysis with the average of the score values, with the average, not the average score values, but the score values with the average of the outcomes. So we found a very, very strong negative correlation. That means that as the score increases, the HbA1c decreases, and as the score decreases, the HbA1c increases, and we found 0.99, 0.97, 0.9. This is a very, very strong correlation between the scoring and the outcome. So this is, I'm showing you graphically the composite score and HbA1c. You can see as the score increases, the HbA1c decreases, and similarly when the score goes down, the HbA1c goes up. This is from the data that I have collected over a long period of time in my patients. Similarly with fasting, with postprandial, and then give me 2 more minutes, just 2 more minutes, please. And then we try to assess whether any change in the score has an effect on change in the outcomes. So this is the delta of the score and the outcomes. But here we found an L-shaped relationship. I can explain this most probably because of the patients who are doing everything, who are following their diet, who are taking medication regularly, and who are doing exercise regularly, but probably they need insulin, and people are not going on insulin because that is a measure that we are prescribing. So these results can be probably because of those patients who need insulin are not taking the insulin. Then we compared the patients who were following their medication regularly, different scores of medication, and the change in the scores of exercise and change in the score of diet. Here we compared with the stable medication, if there's a change in diet score and the medication and the exercise is stable, what happens? So what happens is that as the diet score goes up, the HbA1c goes down. So that means that diet has a profound effect on the outcome of HbA1c. Similarly, here we compared the exercise against the background of stable diet and stable medication. So exercise also has an effect on the outcome, that is, it decreases the HbA1c and the sugar values. But diet has much greater effect on the HbA1c outcome than the exercise. This is what we found in the study. So in conclusion, the diabetes management score is very simple. You can do it in your daily practice. You don't need any software. You can just write in pen 3 by 5 or 5 by 5, and this is what I do. M 3 by 5, let's say D 5 by 5 or 4 by 5, and E 4 by 5 and 5. I started using the score when I was practicing in Apollo Hospital, and I used to write on papers because there was no software there, and that was a very long time back. Then I slowly incorporated into my EMR that I developed myself. So this correlates with patient-related glycemic outcomes, A1C, glucose, and PP. Diet controls plays an important predominant role in controlling glycemic parameters, the factors being equal, and diabetes management score may play an important role in motivating patients. So this was a small story of mine. Thank you.
Thank you, Dr. Ajeshji. Please here. So now I think one of the very crucial area while conducting clinical research, that is the ethics in clinical research. And I think Dr. Alok Modi again needs no introduction. May I request you to start your presentation?
Thank you, Shambhu sir. At the outset, a lot of thanks to Patni sir and the organizing committee for this wonderful opportunity in Kolkata once again. And my regards to the respected colleagues on the dais and the stalwarts of the dais. I've been given a very tough topic, which is discussing ethics and dilemmas in clinical research, which is actually a 2-day talk. It cannot be covered in 10 minutes. I'll try to do justice. So moving ahead, there will be 3 verticals on which I will base my talk. One is ethical principles. What are those principles? What is an informed consent in research? And how do you address the dilemmas, especially focusing on diabetes research? Now, the ethical principles in clinical research is a huge document by ICMR running into 187 pages. I've tried to crystallize some important points from there. I hope I do justice to that. So, conducting research, there are 4 pillars which are very important. Something called as autonomy of persons, beneficence of your research, non-maleficence of your research, and whether justice has been done in different aspects in doing the research. These are very important principles before you design a research protocol. Now, what is the principles of essentiality? Something very important is that you want to do research in human beings. Is it required to be done? Basic question. If it is not required to be done, why are you doing it? If it can be done in animals or it can be done in vitro, stop it over there. If it is not required to be done, like thalidomide, for example, so that question should be asked. Just because we want to do research, you can't make humans as subjects. So that's a very basic question, and that has to be approved. That is where ethics committee plays a very important role. If they feel this research is not required, it won't be done, period. So that's one principle of essentiality. Principle of voluntariness. The subjects that you're taking for research, they should be willing to do it voluntarily, not under any cajoling for financial gains or out of their majburi or something, they are forced or coaxed to do. It should not be that way. It should be totally in their hands, and they should have the liberty to withdraw from the research at any point of the time, irrespective of the damage it causes to the research. So the volunteers who are doing it should have full 200% freedom in participating in the research. They should not be exploited. The selection should not be at discriminatory level. It should be based on ethics, genetics, area, socioeconomic status and all, unless the research demands it. And there should be no exploitation, there should be no discrimination, and there should be enough safeguards in place so that in case the research is going in the wrong direction, the research can be tailored in the right direction. That is another basic vertical on which the research has to be designed. And very important, if I decide to do research on some new molecule of GLP agonist, fine, I'm doing it, I'm doing a wonderful job, I give XYZ results. How does it help society? If I can conclude a research which is doing phenomenal work, like I remember a very wonderful research by Dr. Rakesh Parikh is sitting here. We had a presentation by him and Dr. Shashank Joshi on the obesity index, which is just a ratio of height and weight. How does it help? Is it important? It helps. It beats away a lot of complicated parameters that you're doing. It is unilateral. I mean, it is a universal tool for all sexes, all ages, all ethics. It is going to help society tremendously. It can be one tool which can be launched in the rural areas to the most uneducated people and give you fantastic results. So how is it relevant to society? That is very important. So if there is a social responsibility, then that research should be promulgated and should be encouraged. Another very important pillar is ensuring privacy and confidentiality. Whatever data comes out, you're entering into the private lives of your volunteers. You're getting their private data into the picture, into the literature. It has to be very clearly maintained, and this is paramount. And since I am also a part of the medico-legal committee back in Mumbai, doctors have landed in trouble with Maharashtra Medical Council for revealing the identity of your patient. So whenever you're presenting a paper or a case report, it is paramount that you don't disclose the identity of the volunteer or the patient in any way. If that identity is not maintained, if it's compromised, it is absolutely unethical, unacceptable thing. There are some caveats to that. If a person is HIV seropositive because of the research, or if there is a person is going to develop homicidal or suicidal tendencies because of the drug he is exposed to, or if there is a court order, then that confidentiality breach is broken. Otherwise, confidentiality should be maintained at any time. Now, there are a set of another 40-50 guidelines which are laid down by ICMR. I can't cover everything. To summarize, there should be risk minimization. If whatever molecule or research you are doing, it should not create a huge risk as an outcome of the research. It should be with minimum risk. Who's conducting the research? Any Tom, Dick and Harry cannot do it. Unless you're qualified, you have the necessary qualifications, you shouldn't be allowed to do the research just because you have knowledge of the research. The research should be done in such a way that the society gets the maximum benefit. I've already covered it. Where do you do the research? Do you have the right infrastructure? So for example, if you're giving a drug, person develops myocardial infarction, do you have an ICU inside? Do you have an ICU nearby? It should not happen that because of your research, a person loses his life. So it's okay if he develops a complication, but do you have the right infrastructure to take care of all the adverse reactions? And this is something very particular by the ethics committee. If they don't see that, they don't approve of the research. So your institution has to be approved in all aspects. Is there a transparency and accountability? I will be discussing that down the road. Pharma companies have a big role to play here. There is a lot of research, especially in artificial intelligence. I'll talk about it, where the researchers are funded and they decide the ethics. And in AI, we have seen, the paper that you would be seeing in the public domain soon, many companies in AI have removed the ethics committee, have modified the ethics rule to suit their financial gains. So that's very important. Totality of responsibility and something beyond everything is How much damage you're doing to the environment? Is your research causing leakage of pollutants like heavy metals and all? That is another thing you should think of. So on these principles, you have to think about how to design a research. So do you care to design and conduct the research in such a way that you maximize the benefit to society and minimize the loss to society and to the participants? The plan of action, the way it has to be done should be honest, transparent, communicated, and it should be very well laid down in print, and then it should be followed. Second main vertical for my today's talk is consent. How do you take the consent? Remember, there is a caveat. I'll just deviate here. I'll talk again on medical legal. There is a big difference between consent and informed consent. A consent which is taken on the blank page and you're made to sign is not a consent which is legally valid. An informed consent is if the content of that consent is explained to the volunteers in a language that he or she can understand, and you're sure that he has understood. That is informed consent. If that informed consent is not there, many hospitals and doctors and institutions have paid a heavy penalty in court for not following that. So there are a lot of caveats to that. The consent form should mention clearly that this is a research. It should clearly say that this is a research which is being done for purpose ABC, and it has to be in a language which that person understands, not in medical jargon. The duration of the participation, the number of participation, and how many times the participant has to come. So suppose he has to travel from Bangalore to Chennai for the procedure. How many times will he have to travel? Who will fund it? And is it required to travel so much time? All that has to be clearly explained. The kind of data, whether the serum would be collected, whether semen would be collected, where ova would be collected, blood would be collected, all that should be clearly outlined. Benefits to the participant or the community should be very clearly mentioned over here in the consent form also. And the consent form should very clearly say what potential risk, there is no risk, but what potential risk. So he could be told that so-and-so drug can cause a heart attack. You want to come? Come. You don't want to come? Don't come. I was a volunteer of couple of research when I was doing my fellowship in US. I was made to sign multiple papers. I was told you could land up in trouble, but we will pay you so many dollars. You decide what you want to do. So there's a way of doing it, but I'm just sharing with you. Any kind of inconvenience to the participant should be outlined very clearly in the consent form. Confidentiality will be maintained, and when it will be broken, and when the confidentiality will not be working, should also be clearly mentioned. The reimbursement, how much payment you're getting, and how will you get it, when will you get it, and by what method you will get it, everything has to be clearly communicated, and the ethics committee sees that very clearly. In case there is a complication, so suppose you develop an MI, you have to be treated for an MI in a hospital, who will pay for that damage? Who will take care of the entire expenses? That has to be very clearly communicated to the person. So the freedom of the person has to be clearly outlined, whether he wants to participate in the research, and the caveat is that if he doesn't want to participate and withdraw, that also has to be recorded in the consent. And what is important in the consent form, who's the principal investigator, who's the co-investigator, their names, their addresses, their phone numbers, everything has to be very well documented when you're doing that consent. Another important point is, suppose you're giving the consent, he should also know that if I'm being subject to this research for so-and-so molecule, I may not participate because there is a better molecule in the market already available. I'm a diabetic, I'm made to undergo a new brand of GLP, but I have another GLP which is giving me good results. So do I want to be subject to this? Yes or no? So I may think that I don't need this new molecule, I've got this molecule, I'm doing well, why should I subject my body to that? That also has to be maintained in the research. And if the research is going to lead to HIV or some other complication, that also has to be documented. And if insurance is going to cover the research from the center, that also has to be mentioned, that your expenses will be taken care of by the insurance, not by the institution. So these are all part of the research process, the consent form which has to be highlighted and documented well. And before requesting the consent of the individual, couple of forms have to be filled. There is an ICD form, there is a PIS form. Both the forms are linked with each other. Both the forms have to be properly filled and documented. Necessary consents have to be taken. And a very important part that we forget, and most of us sometimes don't do, you don't ask a person, talk to him in detail, make him sign. You have to give him some time. Let him talk to his friends and families. He may not take the decision there and there. Give him some time to discuss with his family and friends and then come back. This is an important caveat that we may not follow. So that is very important, and that is how consent should be taken. So I've just sort of touched it in brief, how a consent has to be taken before you decide to do the research. So I've covered two main pillars of research ethics. Now the third main pillar is some dilemmas that we face, some dilemmas that have been found out, and some research which has been done in a faulty manner. These are the ethical dilemmas. What are those ethical dilemmas? I'll just address that in brief. I'll take them as a problem and the solution. So in diabetes, especially when you focus on ethical dilemmas in diabetes especially, people who have got comorbidities, people who have got complications of diabetes, understanding the medical information can be daunting. This we can see with our own practice. When I talk to my patients about sugar control, I go beyond and discuss with them about cardiac control. I talk to them about kidney control, eye control. They don't understand. They come with a set idea, my sugars have to be normal. They say my fasting PP and HbA1c is normal. Why are you wasting my time? Why are you writing telmisartan? Why are you giving me MRSA? Why are you giving me a liraglutide, which is such a costly thing? So when you're doing this research, ethically, have you explained the complications and the extent and the detaility of your research, what extent you're going and how you're going to help the society? They don't understand. Most of the research which has been done, when the meta-analysis and the Cochrane score and all have been analyzed, they have found after talking to the participants, they did not understand the gravity of the research. They just thought that they are working for diabetes research. So that is another dilemma in diabetes. Complications and comorbidities as part of diabetes is not understood, and solutions are education, education, and education. Vulnerable population. There is a lot of data and there's a lot of discussion that a lot of research has been done in the developed nations like US and Europe. A lot of developing nations, Philippines, Japan and all have been left behind. A lot of research has not been conducted in that area, and the research which has been conducted from those population, especially in the US, the population which were considered were people who were in jail facing murder trial and rape trials and all, and they were forced to go into research. They were not volunteers who had understood. So these are compromised populations who may not give you the right answers, the right data that you need. So do not use vulnerable population because they are forced to undergo research. Solution is they have to be told very clearly, be impartial to them. When children are taken for research, when senior citizens are taken for research, senile people are taken for research, they may not understand. So if you're taking a diabetic who's got Alzheimer's disease, how can you say that he has understood? If you're taking a type 1 diabetes who's probably 1 year old, how can you say that the child has understood what you're doing? So the parents have to be involved, the caretakers have to be involved. These are dilemmas in diabetes which are not addressed properly when researches are being done. Risk-benefit analysis. A lot of research has been done where the risk and the benefit have not been matched. So the risk has been taken into account, the benefit that you would be accruing because of the research has not been explained, and this is not your job, this is the job of the ethics committee. So ethics committee sometimes has not played a clear role, they have not differentiated the two, and they have not sort of mapped mathematically the two, and they have not given the research. And what they have said very clearly in the statement is, not only should you do this mapping, you should update that mapping regularly. As your research is progressing, you should know where the mapping is going wrong, where the risk is outweighing the benefit and vice versa, and the participant should be informed at that time so that if they want, they can withdraw from the research at that time. This is another dilemma in diabetes research which has not been addressed and not followed. Placebo use, a very basic common sense thing. You compare the drug with a placebo. Now suppose I am a diabetic with a sugar of 150 and 300 with an HbA1c of 8, and I am subject to a drug. Fine, I might get results. I'm subject to another arm, which is a placebo arm. So I'm going to be sitting with a placebo for 6 months with my diabetes not being under control. Am I right in doing such a research? So placebo giving in a diabetes research is a very bad thing. You need to find solutions because you're damaging somebody's life to do your research. So either you should have a comparator molecule which is established so that his sugars don't go haywire. So in diabetes research, the study has to be so designed that you just don't use placebo for doing your research. The participant should not suffer because of his disease, because you're not treating the disease to do the research. Conflict of interest, like I already said, there is enough data in the literature where the person who's funding the research decides the outcome of the research, decides how the research should be conducted, which is obviously a biased and not a good way to do a research. And in artificial intelligence, there is enough data coming out saying that the companies which are funding AI tools have removed ethics committee from their companies, have violated the rules of ethics committee, and have promoted the AI tool in such a massive way to promote research without listening to the ethical bargain behind it. So this is a very important thing. Who's funding the research? What controls we have on their funding? And is the funding going to influence the outcome and the management of the research? Equitable participant selection is very important. Whom are we taking? In many researches, it has been found that people who have got disabilities, who are blind or who cannot walk or who cannot talk, have been removed from the research because they cannot participate. So the results you are getting overall is a biased research. If you do a screening on ChatGPT, you will find a lot of data is a very biased data. A lot of data has not been picked up from blacks. A lot of data has not been picked up from the Southeast population by the developed nations. And this is a big talk, and a lot of discussions have already occurred in big conferences. If you attend international conferences, so there is not an equitable participant selection. It should be a huge selection. So suppose you conduct a research on XYZ molecule in only one suburb of Calcutta, you're not doing justice. You cannot say this is interpolated to the entire India. So unless you select the right participants, the ethics of the research is not correct. And the most important part to anything, at any point of time, the participant should have access to treatment. He is not happy, he feels he's got a complication, he should be allowed to break and go to his doctor, his institution, his place for treatment. Access to treatment should not be denied at any time. That is a very paramount statement for the health of the person. And there are so many other pillars and things I can talk about, but then I would cross my time. I've got 30 seconds left. So I just thought I'll touch upon it because I can't cover everything. Before I conclude, I would like to thank all of you for listening to me patiently and tolerating me. And thank you, Patni sir, and this wonderful Calcutta city with the Howrah Bridge. And I was born here. Very happy to be back here every time. Thank you very much for patient listening.
Thank you, Dr. Alok Modi, because you had covered a topic in 15 minutes, which actually takes 2 days. The clinical research ethics is a 2 days workshop. And I think we are running short of time, so we will take 2 questions, if any. Please, Dr. Vidmani, sir.
This is more of a comment from your side as an expert. Recently, there was a very interesting controversy. A paper by a reputed institution had to be retracted because ICMR refused to accept it. You know about the controversy. And the very fact that the COVID vaccination causes excess deaths is itself a very controversial subject. So, okay, that time when they rejected it, we thought maybe the paper was not done properly or something. But then after a couple of days, a research from, I think it was from Sweden or Switzerland somewhere, came that there were a lot of excess deaths with COVID vaccine. So now what is your comment on the ICMR rejecting a paper which may have been genuine, just because it didn't agree with their views?
I think again, this sometimes when we are conducting any clinical research, sometimes doing clinical research and public health problem, this have some conflicts. So when there was a COVID-19 vaccination, if this type of news arises, maybe that hampers the overall public health program. So I think that could be a reason. Yeah, reason. Yeah.
No, basically, if you have touched this point, at the time of giving the vaccination also, it was made compulsory, but it should not have been made compulsory because from the induction of vaccine, it was not for prevention of COVID, it was for decreasing the severity of COVID.
True.
Right?
True.
So otherwise, the mortality rate was less than 0.5%, and what protection the COVID vaccine gave was 0.3%.
True.
So that is why the controversy was it should not have been made compulsory, rather than it would have been voluntarily, then these controversies would not have been arise. So that time also activists like me questioned. I also got all the 3, including the booster dose, but I was against the compulsory when the vaccine is not preventive, it is just decreasing the mortality.
True.
So,
and there arise a very important principles of autonomy, what we are talking about also. So that compromise our autonomy. Yeah. So that is a conflict always between autonomy and overall public health issues. So I think we had a very good discussion today. And to sum up again, when we are conducting research ethics, we need to emphasize on 2 aims. One aim, I am not talking about any money here. One aim is morality, and another aim is also materialism. We talk about morality when conducting clinical research, but materialism is important. If something called as bad science, so bad science never become a good ethics. So it is a multiplied product of both morality and materialism. So if one becomes zero, so overall ethics will also become zero. So we need to take care two in a good context. So once again, thank you, the panelists, and may I request organizers.
That even a negative trial is as important as a positive.
Absolutely, and we need to report. So
we can
so that
discuss
is very
this
important.
all with Dr. Anil Virmani and Dr. Vital Gupta, sir. Somewhere there, please. Okay, so we move on to the next one.
Next symposium is a tech symposium. For this session, I would request Dr. Amal Bhattacharjee and Dr. Binod Abhichandani to chair the session. And speaker is Bharat Sabu. Topics is artificial intelligence and machine learning in diabetes management.
So, welcome Dr. Bharat Sabu.
Yes.
We'll talk on the very important topic of
Sir, podium is yours,
artificial
sir.
intelligence, which might help with clinical examination and reports, how to monitor the patient, how to diagnose and how to manage well. So over to Dr. Bharat Sabu. Podium is yours.
Good morning, everyone. First of all, a big thank to Dr. Vijay Patni sir and the whole team of DRWA for calling me here. And thankful to chairpersons for the kind introduction and setting up the tone so well. The topic which has been assigned to me today in next 15 minutes or so is artificial intelligence and machine learning in diabetes care. How are the applications working and what is the future with us? This is actually a vast topic but very interesting, and everyone is getting day by day interested into this, because this may be the scene of the future when patient may say to us that I want a second opinion, and we will open our laptop and say, I will give you a second opinion, don't go anywhere else.